Misha was with us last year at our annual meeting. I'm starting the recording, Misha, if that's okay.
Sure.
And that was a time when we were washing our fruit and vegetables coming back from the grocery store, wondering if we should be opening our mail without waiting a week. Lots of exciting times then. And Misha even shaved off his beard at that time, so the mask would fit his face better. Misha, yesterday we heard Eva Parker as well talk about the work for climate change and dermatology. So if you have any extra time, I can fit that in too. We'd love to hear about that too. But Misha Rosenbach from the University of Pennsylvania, thanks for coming back and joining us.
Sure, thanks. Thanks so much for having me, and thanks for the warm welcome. And it's a great lineup that you have here. And I'm sure I have nothing to add to what Eva said. And I will say, if I knew that I would be following that positive exposure talk, I never would have agreed to talk. That's so high energy and exciting and optimistic and positive, and like really like brings a tear to your eye. Like, hey, you take care of these patients. And I think that the idea of, you know, going to like Camp Discovery and things as sort of getting to know the people outside of the disease and the humans behind the patients is so important. And I think that photography effort really highlights it. And I will try to show you other types of pictures to make sure that you see some stuff, because I know popular derm talks show a lot of pictures, but I'm going to go through. I thought it's nice to be back, because you're right, when we were talking last time, it was very early in the course, and this is a little bit later in the course of the pandemic. And I will say that the speakers coming after me, Dr. Esther Freeman, is really one of the driving forces behind basically everything that I'm going to say in terms of like data and new understandings that we have. And so I'm on the AAD's ad hoc task force, but what I say is going to be hopefully evidence-based and represents sort of my own feelings, thoughts, understanding, best synthesis of the literature, not necessarily the position of the Academy, although I don't think I have anything particularly controversial. And so, you know, it's interesting. It's interesting being back here, talking about a year after, I think, the last one, or maybe 11 months after the last one. And I think looking back, I remember I was on service rounding in January in the hospital, and there was this announcement that China was building a hospital in 3 days and that could hold 1,000 patients. And you know, we were rounding and saying, well, you know, still it's flu season, we should be more worried about the flu. And there was a lot of uncertainty about, you know, what lay ahead of us. And then the very early reports from the pandemic that started coming out, first from Wuhan, and then when Italy sort of bore the brunt of the next country to kind of be devastated by the pandemic, showed that there was relatively low rates of skin involvement that were reported out of China initially, although then there was a kind of speckling of reports that came out of Italy relatively early on in the pandemic, and then isolated case reports from some other countries that really seemed like it was going to be a big question as to what we would be seeing as dermatologists. One of the first impacts, I think, of the pandemic was on our practices. And, you know, I'm a program director. I have a separate like half-hour talk actually for Esther's session at the AAD VMX, which I hope you guys are attending, about the impacts of the pandemic on resident education. But I think as practicing dermatologists, all of us sort of noticed the immediate switch to sort of depopulating our clinic, clearing out waiting rooms, trying to optimize for seeing patients who needed to be seen in person. And there were a number of papers that came out early on, sort of how practices should adopt to taking care of patients in the midst of the emerging pandemic. And one of the first concepts that I think was driven home to all of us over the course of the year was this sort of importance of what flattening the curve and trying to make sure that we were not contributing to spread of the disease, to make sure that we didn't go over health system capacity. And as I know you all know, in some places we of course did go over health system capacity. And then early in the pandemic, again, the other thing that dermatologists were very involved in were seeing frontline providers who were you know, working very long shifts in a period of uncertainty with shortage of PPE, and trying to reuse and recycle personal protective equipment, and then helping identify and manage and sort of support other healthcare providers through their frontline care, and sort of, recommendations for contact dermatitis or trauma from N95 fit masks, and dermatologists are familiar with managing these things, but even simple recommendations like, well, you should put, a Duoderm strip over your nose was really controversial, actually, because, N95 fit, you said I had to shave off my beard. And so last time I talked, I think this might be the only lecture that I've given without facial hair in like 20 years, but was so that you could have a tight seal of your N95 mask. And so just telling people to put a Duoderm strip over the top of their nose to protect them from abrasions and trauma sounds like it's sort of common sense dermatology care, but in theory, then that could create gaps and let in potential infectious particles. And there was so much uncertainty about what construed appropriate masking and appropriate PPE kind of really throughout the first portion of the pandemic. And so this has been documented in a number of publications. I'm not going to go through in detail, but basically all healthcare workers had suffered some degree of skin injury from masking and gloving, and the numbers were as high as 97% of frontline healthcare workers who had skin issues, certainly early on, at least during the pandemic. But then we started understanding a little bit more about what was happening with the disease and what was happening in the skin. And I share this, this is a picture actually from one of our dermatopathologists named George Zhu, who's actually from Wuhan. And so he has friends and family in Wuhan. And so we said, well, it sounds like this pandemic is scary, but there's not a lot of skin issues. And he said, well, yeah, I know there's not a lot of skin issues reported, but I have colleagues who've sent these pictures of patients with necrosis and ischemia and biopsies that show intravascular thrombi. And this was, I think, for me, we saw these pictures in January, very early on, and this was sort of a red flag of we should, keep our eyes open and see what dermatology's role is really going to be in the pandemic. I think if you haven't seen this paper, and I know Esther, I'm going to show all your papers. Esther has done tremendous work with illustrating the skin issues in the pandemic. This for me is like an essential paper that should go down in like derm history. And we have like a little file of things that we feel like all residents should read. This was a beautiful effort from Spain where many of the dermatologists were communicating with each other through WhatsApp and social media and describing what they were seeing. And in Spain, they basically published all of the pictures that they had from all cases of known or suspected SARS-CoV-2 and COVID-19 infection. And again, remembering way back at the beginning of the pandemic, for a long time, we didn't have adequate testing. And certainly in this country for a very long time, we had no screening of asymptomatic patients. And so a lot of these are presumed infections, but I would encourage you to check this out. There's over 300 pictures of skin signs of patients who had presumed COVID in Spain at the very first part of the pandemic. And so then the publications that started coming out of this were another publication from Italy that, again, actually sprung up through social media communications between physicians, identifying potential Pernio-like lesions or Chilblains-like lesions or acroischemic lesions in patients in Italy. And then in Spain, there was very similar reports of many patients having these pseudo-Chilblain lesions, and that they tended to be in younger patients following either mild, minimal, asymptomatic disease course, and some of them would have symptoms and some of them would last for a week or two. And then this was a question that then basically is what captivated the early part of the pandemic from a dermatology standpoint. And you could basically Google COVID toes back in April at that point, and it was all over. Google search interest spiked up, and that basically is between April 19th and April 20th, it started going up. And then it went up and up for the month of April and May. There were a number of news articles and news stories about COVID toes, frostbite-like lesions, Chilblain-like lesions. And this is, I think, when Esther and I actually first became friends, although this is supposed to be a lecture, not like a personal shout out. But Esther and I started commiserating that everyone was texting us pictures of toes. And I've selected pictures for you that I think illustrate things, but also I tried to spare you. I have a lot of like funky toes and like hairy toes and all sorts of toes. My phone was just all toes for a really long time, actually. But so we started seeing a lot of communication from colleagues and friends and family members. And honestly, most of the cases I got sent were physicians at my institution who noted things in their friends or family who were concerned about could that be COVID related. And this was kind of the first real consistent physical exam finding that was being reported were these pernio-like lesions. Sometimes they could vesiculate or blister in acral sites. And so this is just highlighting some of the spectrum of those images. They can be sometimes more purpuric, can be on the fingers and not just on the toes. And I will pause for just a moment and talk about pernio. And again, I don't know, I have some favorite papers. This is a really good paper from David Wetter. If you don't know Dr. Wetter at Mayo Clinic, he's actually a great speaker on vasculitis and vascular injury things. This is like a summary of the Mayo Clinic experience of pernio. This is not COVID related. This is like de novo or idiopathic pernio-like lesions. And basically most patients don't have systemic disease. And one of their conclusions though is it's common in cold and humid climates. They have some diagnostic criteria. But the cold and humid climates question is one of the things that became really important, which was, well, we don't have, at the early part of the pandemic, we didn't have great tests available for everyone. And there were questions of how many patients with pernio-like lesions were actually SARS-CoV-2 PCR positive. If you saw pernio-like lesions, did it mean patients needed to isolate and that their close contacts needed to quarantine? Or one of the other theories was, well, everyone went on lockdown and everyone was staying home and people are walking around barefoot in their houses. Is it possible that people are just developing new lesions as part of an epiphenomenon of walking around barefoot at home and not going into work? And the other thing that was happening at this time is the proliferation of teledermatology. And so if this happened in 2017, maybe every March and April and May, patients were getting little red bumps on their toes, but they couldn't send pictures to their dermatologists. And it wasn't all over the news as something to maybe worry about. And so maybe every year in March, April, and May, hundreds of people get little red spots on their toes and they just pay it no mind. And so this was one of the questions that really sprung up. And these are some patients of mine who have true pernio from pre-pandemic era. But besides the pernio-like lesions, there were really bizarre lesions that were also being identified and seen. These acral purpuric lesions or acral erythema at sites of pressure, like over the heels. There were patients who were developing urticarial eruptions in the setting of known SARS-CoV-2 positive PCR testing. These sort of papulovesicular eruptions that were reported as a potential rare sign of COVID, morbilliform eruptions in patients, although many of these patients were on a number of medications. And as you know, it's very hard to suss out the etiology of a morbilliform eruption. And then some more severe eruptions. So erythema multiforme-like lesions with 3 zones of color or true target lesions. And this is a patient of ours in the ED who had a history of quiescent erythema multiforme that had last erupted, 4 or 5 years ago, developed SARS-CoV-2 and exploded in the worst erythema multiforme of his life. And early on in the pandemic, dermatologists were saying, well, we think that these lichenoid pattern eruptions are interferon mediated, and we think pernio-like lesions are interferon mediated, and there are overlap similarities between some patients who have pernio-like lesions and who have interferonopathies, and maybe interferon will play a role. And dermatologists could contribute to the evolving understanding of the pandemic by knowing the pathophysiology of different cutaneous manifestations and what immunologic underpinnings cause us to see those skin manifestations. And so at the MedDerm Society meetings in April, Ed Cowan from the NIH actually talked a lot about the potential importance of interferon in the pandemic and maybe interferon switching and different interferon at different levels of interferon portending potentially different outcomes in patients with COVID. And then besides erythema multiforme, there also were, again, other vascular or severe potential signs that were being reported, including kind of unusual livedo presentations. And so this unilateral livedo is not something that we normally see. And then people who are developing true kind of acral, not just pernio-like lesions, but more livedoid lesions with some maybe duskiness or ischemic changes. And I apologize for the quality of the picture, although I think this illustrates a ton of things that are important about the pandemic. This is from colleague Helena Pasieka in DC. In the pandemic, we didn't know, like you mentioned, washing vegetables and washing fruits and stuff. So all of our cameras were wrapped in plastic because no one would take their phones out in the rooms. So a lot of the images from hospitalized patients are actually through like multiple layers of Ziploc bag and things like that. And so I think you can see there's ischemia and jagged acral purpura here, retiform purpura, suggesting intravascular thrombi. And again, dermatology early on identified thrombi in the skin in patients with severe COVID. And so this morphology, retiform purpura, dusky, jagged, livedoid changes, if you biopsy it, you see thrombi. This was seen in patients who were critically ill with COVID, hospitalized in the ICU with challenging ventilation requirements. And it was dermatology that was one of the first fields to suggest that the hypercoagulability and the thrombosis was something that might be really significant. And of course, I don't want to overstate our field's role. The intensivists and the ED doctors and the medicine doctors who have borne by far the brunt of the pandemic deserve all of the credit. It's been a challenging year for us. It's been a nightmarish year for many of our colleagues across medicine. But still, dermatology had a role to play. There's a paper that suggested that maybe complement cascade involvement was playing a role in response to endothelial damage from the virus. And these are some pictures from patients that we've managed at Penn. And this is when a colleague of mine, Catherine Steele, was on service. Is again retiform lesions. They were kind of the development of funny bruises. And this is actually because we were seeing a lot of patients who were intubated and ventilated in a prone position, which we don't normally see. And so we were seeing a lot of bruising and ulcers and pressure wounds in different sites from the physical nature of supporting patients with severe COVID-19 on the vent in prone positions. So there's all these different manifestations that are impossible to sort out, and all of our data and understanding was coming out in case reports and case series and social media and whatever's on Google search and whoever saw this. And you know, I'm on that editorial board at JAMA Derm, and I can say that for JAMA, there were 3 times as many submissions, which is already a busy job, and 3 times is a huge number. I'm sure it was the same at JAD and BJD and JADV and all these wonderful derm journals. It was very hard to find reviewers during a pandemic when everyone's overwhelmed, and very hard to find anyone who knows anything about this. And so the quality of the literature that was coming out was really challenging. The AAD formed an ad hoc task force that was led by George Caruso, the past president. And I think actually that, without exaggeration, the key member is Esther Freeman. And so our field should applaud Esther and her really heroic efforts to launch the AAD Derm Registry. And this is where we started getting hundreds of reports that then could be sorted through, not necessarily in terms of like knowing the numerator and denominator of things. We don't necessarily know of everyone with COVID or suspected COVID versus everyone with known COVID, how many of them had skin manifestations. There's not an international report like that. So this is basically submissions, and by definition, this is a collection of basically cases that are reported, or a case report, but it does give us a large number to try to sort things out. And so this is, I think, the first major publication. I think this pairs nicely with that BJD publication that's basically was an atlas of what they saw. This is really defining the spectrum of COVID-19 associated dermatologic manifestations. And it was an international registry. So the AAD is the American Academy of Dermatology, but there's collaboration with colleagues across the world. This basically helped sort out into the fact that and Esther, don't judge me for this, but in the middle, there's a bunch of vague, I don't want to say BS, it matters, but non-specific skin findings that don't really tell us that much about what's going on with the patient. People can have hives, people can have macular erythema, morbilliform rashes, but this doesn't tell us much about what's going on. But what was important was the identification of, on a mild spectrum of disease, patients would have pernio-like lesions. On a severe spectrum of disease, people would have retiform purpura. And then we were able to sort out their symptoms and what else was going on in those patients at the time. There was another paper that was focused specifically on the pernio-like lesions that also was put out by the same group led by Esther. And this went through kind of a number of pictures, talked about the types of patients who would present with this, generally healthier, mild, potentially asymptomatic patients. Some patients would have symptoms. And then this is where a lot of the controversy comes up. And I know there's a chat comment, and I'll try to address that actually with the next couple of slides. And the number changes a little bit, but about 20% of patients with pernio-like lesions were testable, were tested or positive for SARS-CoV-2. So again, these are case reports, so it's a selection bias, and 1 in 5 were actually positive. So does that really mean that this is something that we see with COVID or not? Well, pathophysiologically, it makes some sense. But even moving all that aside, early in the pandemic, we did not have any screening. We're really, actually at this point, just getting to where there's enough testing that we're just like screening people and have that low test positivity. And we don't have at-home tests and things like that. So testing wasn't always available, especially in the first wave, which coincided with the cold, damp weather. It was very hard to sort out if people actually had SARS-CoV-2. So many of these are, well, I had a family member with SARS-CoV-2 and I was asymptomatic, but I had perennial-like lesions. Well, perennial-like lesions tend to follow mild or asymptomatic disease. Maybe that makes sense. The truth is, though, our most important role was identifying potential infections and stopping the spread. And so if 20% of people with perennial-like lesions are SARS-CoV-2 positive, well, I'd rather suggest isolation for 80% of the people unnecessarily than not suggest isolation for 20% of the people who then, without that guidance, might go out and spread the disease. And so I think our job has been to flatten the curve, err on the side of caution, follow the most conservative approach to preventing spread of infection. And this is a hint that probably not everyone with pernio in 2020 had COVID, but a subset of people with perennial-like lesions probably did have COVID, but COVID was all over. And so I don't think that dermatology is like the driving force behind the pandemic, but I think our job is to know what's out there. So getting to that chat comment, I think, actually, before I get to that chat comment, one other important issue, and the issue of representation in dermatology has been talked a lot about in 2020 also. You might notice that most of the pictures I showed you were in light skin. So one issue with teledermatology, it doesn't necessarily capture erythema in different skin backgrounds quite the same. One issue that we have in dermatology, we don't necessarily show skin of color images besides lighter skin images for every talk and every chapter and every textbook. And one issue that was very apparent early in the pandemic was a lack of representation of what skin lesions in patients with SARS-CoV-2, COVID-19 might look like in darker skin types. And so there's a publication in JAD case reports that tried to fill that gap and did highlight that these types of lesions could happen in patients with all different types of skin color and skin pigmentation, all kind of throughout the world. So getting to that chat comment, there has been a controversy over, is perennial-like lesions, are these actually related to COVID-19? Or is it just that we're hypervigilant and paying attention to stuff we would normally not worry about? And there are arguments on either side, and without pointing fingers, these are like probably the louder voices on either side. And I don't mean that in a derogative way. I mean, the group on the right has published a number of papers sort of arguing against the true strength of association. Group on the left, of which I co-published with, and so that's probably my bias, has published that there is a potential association. And there have been a lot of studies trying to get at this. So there have been biopsies of lesions that look and find SARS-CoV-2 spike protein in the endothelium and eccrine coils of patients in their perennial-like lesions. Well, that's interesting. But then an argument has been that, well, they haven't actually shown EM showing virus in the perennial-like lesions. And then there have been other efforts that have shown immunohistochemistry demonstration in the endothelium of patients with perennial-like lesions who are SARS-CoV PCR negative. And so arguing that maybe, and Esther's published actually a little bit about the timing of testing, that in patients with mild infection, by the time they develop their perennial-like lesions, they probably had their COVID 2 weeks ago, asymptomatic. Interferon response leads to the perennial-like lesions. And then if you test them at the time of their perennial-like lesions, they actually haven't yet mounted their IgM or IgG antibody responses. So they've had an interferon spike, it controlled their virus, they haven't yet mounted their antibody responses. And so we really need to do better work to sort out the strength of the association. It is not an open and shut story. And I don't mean to say that everyone with pernio has COVID, but it's something that dermatologists should be aware of, and our field should be involved in sorting out. Very briefly, there have been other things that have emerged over the course of the pandemic that pertain to dermatology, including the multisystem inflammatory syndrome that can closely mimic Kawasaki's disease, particularly in children. This is more severe, and there have been rumors and hints that with some of the variants of concern, we might see things like this more frequently. You also hear about long COVID, so long haulers or patients who have COVID for a long time. From dermatology standpoint, there is some evidence that some patients who had some of the cutaneous manifestations that have been attributable to SARS-CoV-2 infection have those symptoms for a long time. And some of them have shown some recurrence, where people who developed lesions in March when it was cold and had COVID, then when it got cold again in the fall or winter, had flares of those same perennial-like lesions. And just intellectually, we don't know what causes idiopathic pernio. I do not think it would be a shock if it turned out that mild viral illness in the winter that was largely asymptomatic and controlled by host immune response and rising levels of interferon could lead to pernio-like lesions. And a subset of those patients might have persistent either endothelial damage and inflammation or trigger of true de novo autoimmunity. And it might be that our better understanding of pernio-like lesions in the setting of the SARS-CoV-2 pandemic might help elucidate the etiology of previously thought of as idiopathic pernio. And the last thing I'm going to close with is the new thing that's filling my phone, which I love, which is Moderna arm or COVID arm. And literally, I was in resident clinic yesterday. I think we saw probably, I don't know, 20, 25 patients. 8 or 10 of them had big like red macules or patches on their arm. This is certainly underreported, also not scary. So people get these red patches at the site of their COVID vaccine, more common with Moderna rather than Pfizer. And we don't know yet about J&J, and I will get to a final plug about that. There's a paper that actually Esther's also co-authored on. It was put out by Dr. Blumenthal, who's an allergist at Mass General, sort of highlighting the spectrum of post-vaccine reactions, which have been classified as primarily like a delayed hypersensitivity that can develop even 1 or 2 weeks after the Moderna vaccine can recur. You can do one arm and then the other arm and have it at both sites. You can have it after the first one and not the second one, or the second one with not the first one. None of this is scary, does not require antibiotics. Topical steroids, antihistamines are fine. I will say that as someone who practices in Pennsylvania, which is the Lyme capital of wherever, as soon as it's Lyme season, which hats off to Eva Parker and climate change talk, guess what? It's unseasonably warm, and Lyme season starts earlier every year and moves northward and westward every year. So it is already Lyme season now. And so if I see patients with this 2 years ago, I'm giving them doxycycline. If I see patients with this now, I'm high-fiving them for being vaccinated. But I do worry that I will miss the one Lyme on the arm. One of the ways that we'll understand better about, and the last thing is all of these are white skin. And so there are, the pandemic has disproportionately affected different groups. And you can see maps of zip codes that were more affected by COVID cases, but are least distributed with vaccines. And so this is an issue with equity and fairness. And it might be an issue with that this doesn't happen as much in dark skin. It might be an issue that it's harder to capture over photographs. It might be an issue that it's not as reported, or it might also be an issue that we haven't done as good of a job fairly distributing vaccination fully among the population. Although the Biden administration has really ramped this up. And I hope that by May, really we have 70% or more people vaccinated, and that we also see a bunch of representative images of vaccine reactions in darker skin types as well. If you do have those, or patients who have vaccine reactions or still COVID skin manifestations, the registry is stronger and we learn more the more people who contribute to it and participate in it. So I would encourage you to take like 4 minutes to upload something. Esther's probably gonna text me that I have to upload all the pictures that I should, and I haven't entered half of them in the registry, and she's gonna be mad at me. That's true. Thank you to all of you for listening. Thank you for working so hard over the past year to take care of your patients, and your families, and yourselves, and your friends. Thank you, Esther, for making the registry and teaching our whole field about skin manifestations of COVID. And thank you guys for inviting me.
Thank you, Misha, for a great summary of the year. I assume you've heard that the AstraZeneca vaccine has been halted in Europe due to hypercoagulation. Are you aware, or Esther, you're on the line too, are you aware of vaccination reactions to that being more common, or other manifestations in the skin?
I will pause slightly, only because that's a great question. The epidemiology behind that is actually very tricky. And I actually think that this touches on another thing that we learned about that touches on both climate change and the pandemic, which is the role of misinformation. Not that you're participating in misinformation, but vaccines and the link to autism drives a ton of decision-making, and there is no link to autism. But that is a pushed misinformation thing that now many places are worried about any association of anything bad with vaccine and potentially leading to vaccine hesitancy without strong data behind it. And so the rates, actually, I'm not an expert on this, but the rates of clotting in AstraZeneca vaccinated people is the same as in the population. It's an incredibly rare event, and people get clots incredibly rarely. And so it's not like a 2 to 1 or a 10-time fold or even a 5% increase. It's basically the same as like if you look at the rates of clots like 4 years ago versus the rates of clots now with AstraZeneca vaccine, it's the same. It's just that there's the fear of the perception of, well, we have 5 vaccine options. If this one has a potential hint of a threat, if we don't act and it turns out that down the road it's real, then we're going to be in trouble. Or if the rumor mill starts churning that there's danger with the vaccine, we're going to continue to deal with vaccine hesitancy. And there's a ton of really like cyber warfare level misinformation about vaccines being pushed out to try to get the American population to not get vaccinated. There's, I don't want to be like a conspiracy theorist and whatever, but like with climate change, there are vested interests that push a narrative that's not borne out by evidence. We have seen over the course of the pandemic that people like saying things that get them attention if it's not borne out by science. And we do have to be really careful about making sure we're always making scientifically guided and evidence-based decisions. And the AstraZeneca concerns are really tricky. If you look at like Brazil, where their country is just devastated, if you could just give the AstraZeneca vaccine there, you would do so much more harm than any potential hurt. That there are real ethical issues and challenges around what we should and shouldn't be doing with this. But I'll stop rambling because, yeah.
I think one issue around the AstraZeneca vaccine, for me, to be honest, is in some ways less about the clotting and more about the question of, is it efficacy against the South African variant, which I apologize, I shouldn't call South African, I should call it by its proper name, but I just can't remember the number off the top of my head. I think, you know, I work a lot in sub-Saharan Africa, and right now the issue about vaccine nationalism, I think, is hugely important. I think we have issues both in the country, within our own country, about where vaccines are being distributed, and then internationally. This idea that, you know, the global South, many of these countries are not predicted to really have like reliable vaccine access until late 2022, 2023. And that really, I think the point is that it really hurts all of us because, you know, variants are going, the fewer people are vaccinated worldwide, like the more variants are going to propagate. And so it's really not like a borders issue. It's an issue for all of us. And so a bunch of so really had the first vaccinations in Kenya of healthcare workers in one of the hospitals that I work in this past week, which were AstraZeneca. And, you know, the question that I have, to be honest, more than the clotting, which I share Misha's concerns about how strong that data is actually, you know, are we giving what's going to be an effective, and I don't truly know the answer to this yet, right? Because there wasn't a lot of data on it, but are we truly giving what's going to be an effective vaccine in Africa or not?
Any questions from the audience?
Oh, and to answer your question, really quick, Bob, we do not have enough AstraZeneca data in the registry to get a sense. And so I really would encourage especially our European colleagues where there may be more AstraZeneca. Our registry right now for the vaccines is definitely biased towards North America. So we're really more seeing Moderna and Pfizer and now some J&J, but I would love to hear more about, Sputnik vaccine reactions. I'd love to hear more about, AstraZeneca and all of these. So yeah, definitely spread the word.
I will say you went from the like most positive exposure, high energy, awesome year, and then like I did like a COVID typical derm talk, and then I went into cyber attack and misinformation, and we've gone downhill very fast. I do want to say it's an absolute miracle that we have like 5 or 6 vaccines and that they work this well. And I'm so happy. I like the fact that it's spring and daylight savings and I got vaccinated. Like there's so many like happy things recently. I do want to end up like the fact that a year ago we were like washing our vegetables, and now I would hope that most people on this Zoom are vaccinated. It's like tremendously exciting, super awesome, like science. Thank goodness for science. And I'm like so happy and hopeful, and just I'm delighted to get to participate in this. And I don't want to end on they're trying to get us not to get vaccinated and everything's bad. No, magical vaccines are amazing. Super happy.
Yes, I think we are all very pro-vaccine, especially for a disease that can lead to death quite readily among people who get it. Last year, we had maybe 3 times as many people on the call because everybody was scared and wanted any little piece of information anybody could provide. And I think just the fact that we are all calmer and happier this year is a great testament to science and to the work of the many physicians, including you, Misha, and you, Esther, on doing at least our dermatology part in this pandemic. Thank you so much, Misha, for being here. I see we're at time now for Esther to now take over the mic, the talking stick, along with Lindsy Fraser-Green. Lindsy is one of the coordinators of the guideline efforts at the AAD, and Esther is the clinical guidelines chair. And we are so happy to have you here and talking to us about modernizing AAD guidelines.
Great, thanks so much, Bob. And thank you, Misha, for that great talk. I think you really did a complex issue a lot of justice. It's actually really fun for me to listen to somebody else talk about COVID dermatology. So I really appreciate the chance to kind of sit back and hear your take on it. Delighted to be here today with my other hat on. I feel like I've been 98% COVID for the last year, but the other piece of me has been working on our clinical guidelines for the American Academy of Dermatology. And it's been an interesting time for us because we've also been trying to put out some kind of interim guidance around COVID-19. So it's been a little bit of a wild ride for all of us. I'm delighted to also have Lindsy Fraser-Green with me today, and I'll allow Lindsy to introduce herself.
Hello, thank you for having me today. As Dr. Freeman mentioned, I am a manager of clinical practice guidelines and research at the American Academy of Dermatology, and happy to share what I hope is some positive news about all of the efforts to modernize the AAD's clinical guidelines portfolio.
And we're particularly excited to be here today, just because I think this is the beginning, and this is not that we already started, but the beginning of really hopefully a close relationship between guidelines from the AAD and Cochrane. Because I think that can be a really, and I shouldn't say the beginning, we're already well into a relationship in terms of some of the upcoming systematic reviews, but I think it's just a really great opportunity that I think can be beneficial on both sides in terms of the collaborations between guidelines and Cochrane. Excellent. So no disclosures relevant to this talk. Next slide. So I just wanted to kind of give you an update on where we are with current AAD guidelines. So our current portfolio includes 8 different guidelines, and generally these are considered to need an update every 5 years. And we'll talk a little bit about how we're hoping to actually keep these more up to date more frequently than every 5 years, but traditionally it's been every 5 years. Right now, actinic keratosis is our latest. It is completed and it's expected to be available online later this month or early next month. So this one will be published very soon. So keep your eyes open for that. And I wanted to give you the sense of atopic dermatitis and acne are the 2 that we're working on right now. And atopic dermatitis is most of the way through. Acne, we're really just starting. Next slide. And so in terms of the pipeline, the psoriasis was definitely a pretty big effort. It was actually 6 different guidelines in one. And the last one of the psoriasis guidelines, and these were all published 6 separate guidelines, were topicals and alternative medications. And that was published in July of 2020. And these were our final, what we'll call like our old guidelines, or the methodology that we're actually sunsetting. And what I want to take you through in this talk, what both Lindsy and I will take you through, is the process by which we've done a pretty massive update of the whole way that American Academy of Dermatology guidelines are created and how conflict of interest is managed. So in terms of what's under development right now, so actinic keratosis, as we mentioned, is just completed, not published yet. That will actually be our first guideline using our new methodology. So we've switched from sort to grade in terms of how we evaluate the evidence. And so actinic keratosis will be our first guideline using grade from the AAD. And then the other ones that are under development right now, atopic dermatitis and acne. Acne will be our first guideline that has the full new conflict of interest policy. And I don't know if you guys are hearing my 3- and 5-year-old in the background, but the joys of working from home when my kids are on vacation, which makes it even harder. So, all right, perfect. So in terms of what is next in our queue for the Academy, and I wanted to introduce, I don't know if she has a chance to come on because I know that she had another meeting. If you are here, Peggy, please say hi, but I think she had like 3 different meetings she's supposed to be in this morning. I wanted to introduce Peggy Wu, who's actually going to be taking over for me. So I've been deputy chair and then chair of clinical guidelines committee, really thanks to Bob, for the last 4 years and chair for the last 2 years. And so during that time, we've really gone through this big modernization change to how we do clinical guidelines. Peggy Wu is taking over for me. And the reason I wanted to put her picture up and have you guys meet her, at least electronically know that she exists, is that she'll be taking over. And I think as we work to collaborate in future between Cochrane and AAD Guidelines Committee, Peggy is the person that we would be working with. So she's based at UC Davis, and she was also one of the first actually along with me, the two of us received the first Cochrane scholarships from the AAD, which is really Dr. Della Valle's brainchild, which is this nice program where the AAD selects 2 members each year and actually sends them to the Cochrane Colloquium to really get, bring them into the fold of kind of Cochrane skin and really get them up to speed in terms of methods. Right now, that program has been kind of on weirdly hold for 2 years, obviously, because of some issues with Cochrane being canceled around the pandemic and around some unrest in Chile. But I think we will, we have a good backlog and we'll continue to run this program. So in terms of where we are with how we prioritize guidelines, and I'm guessing the European groups do this very similarly, we basically run a reprioritization process every few years, usually for us around every 3 years or so. And this goes across the entire academy, where basically all different task forces and work groups, we have different criteria that we basically judge importance of different topics on, so importance to specialty, amount of evidence, things like that. So it's a rigorous process by which we decide our prioritization. So right now in our queue, we're actually about to start a reprioritization, which will fall under Dr. Wu's purview. But right now, what we have prioritized in our current list are updates to melanoma, BCC, and SCC, and all of those would be coming due for update in 2023. So those are kind of some updates. And then another topic that we've had on our queue for a long time that we were excited to tackle is around skin cancer screening. We actually don't have any American Academy of Dermatology guidelines on skin cancer screening. I will say I think that this is a changing area because the US Preventative Services Task Force is right now basically creating, or in the act of working on and creating a guideline on skin cancer screening. The American Academy of Dermatology has contributed a work group to try to give them feedback. There are no dermatologists on the US Preventative Task Force, so it's always a little bit unsettling to have another group that has 0 dermatologists on it, create a guideline kind of for us. So I think, to me, it remains to be seen, and this is me speaking personally, not for the AAD, it kind of remains to be seen whether we end up needing to do our own guideline on this, or whether, we can in some way align with the US Preventative Task Force group. So I think this will be a bit of an interesting ride. And then the reprioritization process will be undergoing in the next, few months. Next slide. Great. And so how do we develop guidelines? And this is, I think, a pretty standard process that's true for other countries and guideline groups as well. We have a work group formation who then identifies the PICO questions and the scope. Systematic literature reviews are then done, and we're so appreciative that Cochrane is collaborating on some of these right now for our guidelines. And traditionally, the AAD, that had been done as an internal process, and now because we're efficiency, we're actually trying to do that externally with groups like yourselves that are really, really and I shouldn't say yourself, I guess I'm an editor now, so ourselves, but groups that are really expert, in the systematic review process, rather than just doing this in-house at the AAD. Then we go through development of recommendations, guideline drafting, and then there's a very extensive approval process that we've been working on trying to streamline a little bit, just because it takes a long time to go through all the different academy approval levels. And then we finally traditionally have gone to just a static publication in the Journal of the American Academy of Dermatology. So the traditional output from a guideline from the American Academy of Dermatology has been basically like a single JAD publication that then doesn't get updated for another 5 years. So when Suzanne Ulbricht was president of the American Academy of Dermatology, she decided to launch a new task force on which I served that was existent for 2 years, with the idea of really trying to overhaul and modernize and really make more efficient our guideline process. And the idea here is to be a little bit more timely, just because guidelines do take a really long time, certainly evidence-based, of course. And we also wanted to kind of modernize it a little bit in the sense of how do we put it in someone's hand and make this a little bit more user-friendly than maybe just, a JAD publication that's kind of hard to access when you're in the middle of clinic and seeing patients and you're trying to figure out which biologic to use for your psoriasis patient. Next slide. So the main 3 things that we changed, and I guess there's kind of a fourth, of modernizing clinical guidance. The first was really how we were grading the evidence. And so the World Health Organization uses GRADE. A lot of other international organizations use GRADE as really, I would say, the standard for grading evidence for guidelines. The Academy still used SWORD, which they've used for a long time. And we really felt that this was not in keeping with the international standard and that we needed to move to GRADE. So that was a big shift. It sounds like a small shift, but it turns out that as we're dealing with the ramifications of this 2 years later, is actually big, because what happens is that all of our old guidelines are still in sort. So now when we want to do an update, it's actually quite tricky, because we have to decide, are we going to do like a whole brand new guideline in grade? Are we going to somehow update the old sort? It's a little tricky when you've got two different systems. So I think we're going through some growing pains right now. And hopefully once we transition all of our guidelines into grade, it's not going to be quite as painful a process, but Lindsay is involved with that. The other piece that we really needed addressing was conflict of interest. And this is huge in guidelines. I view this as one of the most tricky and most important topics that we've dealt with in the last few years. And part of this issue was that, pharmaceutical companies will actively look to pursue people on a guideline. This is not like a passive process. And I always like to warn people, and people are always like very surprised. And I'm like, oh, they will find you and they will come for you. And so, we do know that financial, relationships can affect people's decisions around guidelines. And so this is very important. So we are now aligned with what used to be called international, the IOM, the Institute of, but it's now changed to NAM, which is the National Academy of Medicine. So we are now aligned with National Academy of Medicine guidelines, which is over 51% non-conflicted. We have a non-conflicted chair who cannot obtain new conflicts during the course of the guideline. That was really the problem, was that we always had 51% non-conflicted members, but those non-conflicted members could get new conflicts, then we had to balance them out. And so now we're really freezing people's conflicts. I think that's the most important part. People are really frozen as they enter the guideline process. And then we also work to make it a little bit more efficient. And I think Lindsay will be talking about that. And then the last piece is really modernizing how, we'll talk about it in a second, how the person approaches and interacts with the guidelines. With that, I will turn it over to Lindsay.
Thank you. So as mentioned, one of the focuses of these modernization efforts has really been bringing up to speed our evidence synthesis methods and the way that we move from evidence to recommendation. So starting in 2019, as Dr. Freeman mentioned, we made the official decision at the AAD to transition from the strength of recommendation taxonomy, so SORT for short, to the grading of recommendations of assessment, development, and evaluation methodology, or GRADE for short. So I just wanted to highlight some of the key features of GRADE and how that impacts our guideline development process, starting with what is GRADE. So GRADE is a systematic approach to rating the certainty of evidence and grading the strength of recommendations in clinical practice guidelines. It really provides a transparent means for our guideline developing work groups to communicate how and why decisions were made around the evidence gathered during a systematic review to inform clinical practice recommendations. GRADE's definition of certainty of evidence in the context of clinical practice guidelines is focused on how certain the guideline developers are in the evidence to support a clinical recommendation. A defining aspect of the GRADE approach is its outcome-centric focus. So GRADE evaluates the certainty of evidence on an outcome-by-outcome basis, not a per-study basis. And this is a really big departure from the previous methodology used to develop guidelines. And as you can see, with such a departure, that makes updating guidelines that were previously conducted using the SORT methodology a much different undertaking than using GRADE. So a lot of, as Dr. Freeman mentioned, growing pains around how we can most effectively do that in terms of taking that 8-topic guideline portfolio you saw and turning that into an 8-topic GRADE developed portfolio, while also incorporating guidance on new topics such as AK when the need arises. So again, the immediate focus really is transitioning all of the topics in the AAD's guideline portfolio from SORT to GRADE as they're prioritized for guideline updating. And of course, any new topics that are prioritized for development will start out with GRADE development methodology. So again, as mentioned, to further align with contemporary standards of rigorous guideline development and ensure the integrity of AAD guidance, the task force developed and refined our COI management policies specific to guideline development. Aligned with industry standards, the AAD has traditionally required the 51% unconflicted status of our members, but as we heard, that can arise in conflicts when members are courted by industry and take on conflicts during the guideline development process. Practically, that looks like in the past having to add additional members to maintain that balance, which can result in unwieldy work group sizes, sometimes in the 30s. And as you can imagine, that becomes quite a project management challenge in and of itself. So what the task force is really focused on is looking for ways that we can implement policies and standards to freeze those conflict of interest, even through 6 months post-publication of guidelines. So we're really asking that our unconflicted members who join the panel do not engage in additional relationships through the post-publication period. And we're also asking that if we do have a conflicted co-chair, so in the cases where the expertise of a dermatologist is required to lead the work group, but they are conflicted or have relevant financial conflicts, we require an additional co-chair who is unconflicted to balance those relationships. We're requiring them to freeze their conflicts, even though they are a conflicted chair coming into the process, and really refining how we manage the addition of conflicts for previously conflicted members. So if you do have conflicts, you're one of that 49% of the panel that was impaneled with conflicts, and you do engage in additional relationships, really having a more refined process for how we evaluate those relationships and what management of those relationships look like. And that's anything from recusal from discussions on specific recommendations or topic areas where you have a conflict of interest, or recusal from voting on those topics as well. So I will caution that these policies are currently undergoing consideration for adoption, and we're fairly hopeful that they will be adopted following the AAD's next board meeting. So moving from methods and policy to the timeliness of development and the dissemination process, the task force identified ways to enhance the efficiency of guideline development and dissemination that really focus on 3 key areas. The first being development process reform, the second being efficient guideline updating, and the third being innovative dissemination strategies to move guidelines into practice. So when we're taking a look at our development efficiency changes, we really implemented 2 process-focused reforms to reduce the timeline for guideline production. The first being limiting the size of the guideline work group to between 11 and 15 members as needed. This standard allows for the impanelment of a multidisciplinary guideline development group that includes patient advocates, a methodologist, a measures representative, while balancing the pragmatic challenges of large disparate work groups. As I alluded to, a 30+ person work group can really elongate the timeline for development. Second, the organizational review and approval process for guidelines has been streamlined while maintaining essential organizational perspective and allowing for a full AAD member comment period on the draft guidelines. In practice, these changes look like establishing a 10-day review period for council approval, limiting the number of members of a council or committee that were engaged to review the documents. The total internal review process and member comment period still accounts for about 3.5 months of the development cycle, but this is down from closer to 6 months of the development cycle. Additional efforts to add efficiencies in the development process include outsourcing evidence synthesis. So we heard a bit about that in Cochrane, the Cochrane Skin editorial group. I'm overjoyed to say is one of our partners in this pilot. This process is being piloted for topics of the AD guideline update, so specifically for topical therapies for the management of AD, as well as phototherapy for AD. The aim is to allow for multiple systematic reviews to be conducted simultaneously in support of sections of a guideline. Outsourcing the selected systematic reviews also allows for balancing the aims of simultaneously enhancing the rigor of our development, as we did with our methodology transition, while still maintaining that desire to expedite the development process to produce more timely guidance. So those initially seemed like competing interests, enhancing our rigor while expediting the process. So this is one of the avenues we're exploring to sort of mitigate some of that issue. To further update our development efficiency, we've been working on an approach to an annual literature review that will allow us to more efficiently prioritize the topics in our guideline portfolio that require updating. So what this process looks like now as it's in development is quarterly literature searches on selected topics within the guideline portfolio. The literature identified during those literature searches would be assessed by an expert committee, perhaps the clinical guidelines committee, and then that information about the scope of newly available literature would be used to inform prioritization decisions. And this actually is a sort of precursor or necessary first step to moving into what would be a living guidelines model. Such a model is certainly aspirational, not only for the AAD, but most guideline development organizations. So that's not something we're on the precipice of or nearing, but this is definitely it's definitely a goal in terms of maintaining guidance and developing guidance in a timely manner that can simultaneously be updated with the publication of recommendation important new evidence. So we're striving towards that goal by taking a look at how we can conduct annual literature searches now to help inform prioritization exercises. With that, I'll turn the floor back over to Dr. Freeman to talk about some of our post-development efficiency initiatives.
Thanks, Lindsay. And I think that one thing that's really important to us is how do people interact with the guidelines? And so one thing which was novel and is now entirely no longer novel is the idea of webinars. At the time, right, there weren't a lot of webinars. If you could like rewind yourself a year. And so the idea is that with each guideline launch, we'll really be kind of introducing the guidelines, having a webinar. Now that sounds entirely normal, and it kind of makes me wonder why we didn't do it earlier, but we have to remember, you know, a year ago, I didn't really know how to use Zoom. So we have come like a long way, you know, in a short amount of time. So it's almost hard to remember that, you know, the idea that this would sound like doing a guideline webinar would be in some way novel. But at the time it was, and I think it will still be really helpful. So one option is, you know, we're going to be doing webinars. And then I think the other really important thing is thinking about the electronic format, because people aren't walking around clinic with a printout of the JAD, you know, tucked into their pocket every day. So am I moving on to the next slide, Lindsay? So the idea is really moving this into an app-based format. Many of our providers and certainly our younger generations are really carrying a smartphone in their pocket and they're looking at things in the electronic format. So the idea is how do we turn this into mobile guidance? So we have our first app under development. The first one that we will be launching really as our pilot is going to be biologics for psoriasis. These are tricky to develop after the fact. And so the goal is going to be going forward that we're really doing the app at the same time as the guidelines. But right now we're kind of just going through a pilot phase. So more on that soon. Stay tuned. And I'm very excited for this. You know, in concept, I think it's really important. And I suspect it's going to take a little while to, you know, to really transition this fully and make it live. Next slide. And then I think also thinking about, can we integrate this into an EMR? I know it's certainly in the US, a lot of places use, for example, Epic. Can we help by integrating into directly to become like a decision aid tool? So these are, I think, are all directions we're going. This is going to take, you know, a little while. So it's a continually moving target, but I think the real goal is how do we bring this into people's hands and make this so much easier to use? Next slide. And then just to let you know, we did publish our whole process of how the modernizing clinical guidelines in the JAD. I'm first author on that, and that was published in 2020. So if you want to take a look, there's a beautiful long appendix that Lindsy Fraser-Green put together on the sort to grade transition. So if you have any questions about our conflict of interest strategy or that transition, you can refer to this JAD publication. Next slide. And this is what I actually really wanted to get to, which is this discussion of how the AAD guidelines group can collaborate with Cochrane and vice versa. And to me, I really view this as mutually beneficial because on one side, I think, you know, as someone who's myself written a Cochrane review, the idea that all of that work could then feed into guidelines, to me was very rewarding. You know, the Cochrane review that I did on Kaposi's sarcoma actually ended up informing a WHO guideline. And that to me was actually one of the more rewarding parts, was it's not like you just write this and it kind of sits there for individual people to look at, but that really informs guidelines. And so as a Cochrane author, I think that's a wonderful thing. And then from the AAD perspective, knowing that the reviews that we're getting to put into our guidelines are really high quality, I think is also really important. So to me, it's kind of a win-win. So things that I've kind of passed on to Dr. Wu, who's taking over for me, are the idea of like, can we continue this, more open collaboration of what are our future plans? Because actually the AAD tends to know pretty far in advance, like often 2 years in advance, what our next topics are. And given how long it takes to put together a Cochrane review, you guys kind of need to know. And it may be that that's not a topic that's interesting to your authors. And so maybe it's not a place for synergy, but maybe it is. Or maybe you were going to do something similar and that kind of helps sway one way or the other, which reviews you're choosing to do. So I think, we have some of those right now, phototherapy for atopic dermatitis, and I'm super pleased to hear that we've been touched in terms of acne, which is our next, guideline that will be coming up as well. So I think a lot of possibilities for synergy here. And then the other slide for discussion that I just wanted to bring up was we started to talk with some of the different European groups of how do we harmonize these efforts across the world. And, we have a situation here where we've got some European teams coming up with atopic dermatitis guidelines around the same time as the American Academy of Dermatology teams. And I think we realized this time a little too late to synergize, but in future, does it make sense to have two different groups doing two different systematic reviews on the exact same topic? I would probably argue no. And are there ways that we can collaborate and complement each other? And have future collaborations. And with that, I thank you. And I see a very interesting comment in the chat that I would love to read.
Thank you, Esther. I'll let you, and Lindsay, we have a hand up from Aaron Drucker. Aaron, do you want to open your microphone?
Thanks. Great talk, Lindsay and Esther. So I think, one major issue is that systematic reviews are underfunded. And so, a lot of them are just done, with a few trainees and supervising physicians. And then, even that happens in Cochrane reviews. Whereas, when the AAD undertakes to make guidelines, there's a lot of resources thrown at it. And that includes just, having someone like Lindsay to do high quality systematic reviews to underpin the guidelines. So I'm just wondering, if the AAD, they're willing to work with evidence-based practice centers, they're willing to work with Cochrane, is there going to be money to, work with groups of dermatologists who are doing high quality systematic reviews without any funding, for their research group to do them?
Yeah, I think that's a great question. And the idea is that part of this modernizing process is we started working with the idea of outsourcing. So the challenge with doing them internally, with having someone like Lindsay, who does a great job, do all of them herself, is that she's obviously can only do one at a time. And so if you've got a guideline like psoriasis, which are 6 different topics, she's doing 6 reviews in sequence. And the idea with going out to these evidence-based practice centers is that now you could have multiple reviews going on at the same time and make it more efficient. And this was a model actually that I brought back from working with the World Health Organization. So I was involved in World Health Organization guidelines. And so they specifically, and as you probably know from Cochrane, they specifically contract out to different Cochrane centers for WHO guidelines and other expert centers. And so that's really the idea that we're trying with the AAD. So we're doing it, now with a number of different centers, Cochrane included, as kind of our pilot. I'm really, hoping that this, takes off as our way forward, because I think, as you said, then the AAD is actually paying for a high quality systematic review to be done. And the AAD would have that in its budget anyway, and where it's actually much more efficient to pay somebody else who's going to do a good job with that than to do it internally. So, I do think it's a positive model. I think it's, AAD with COVID this year had a little change in their budget. So we were hoping on contracting more out, and we were actually told we could contract less out, and then we had to do them more internally this year. So to me, that's a small step back. But I think that was kind of COVID specific. We've had AAD in-person meetings canceled 2 years in a row, and that's a huge source of revenue for the Academy. So I'm hopeful that this is still going to head in the right direction. But that's really the goal, Erin, is to, have the AAD funding these high quality centers to do really good systematic reviews, which I think is also a win, for evidence-based medicine.
I see Bob Boyle has his hand up. Bob?
Hi, Esther and Lindsay. Thank you for a really nice presentation, and it's lovely to hear all the processes there and how you're really improving things at AAD in terms of quality of the process. I just had a comment and a question really. The comment is, we'd love to work more closely, and I think when you're talking, I was thinking some of the work that you do in your prioritization is quite similar to to what Cochrane Skin do. And certainly, it would be nice to talk about aligning the prioritization processes in some way. I think certainly your process of looking at the literature, seeing what new publications are coming out, what new trials are potentially changing practice. We do that quite regularly as in our prioritization, and we're pretty good at searching. So I think we'd love to sort of talk about the possibility of connecting those processes in a way. The other was about conflicts of interest, which obviously is a big deal across medicine, and most of the professional societies get funding from relevant drug companies, etc., and the guidelines mostly come from the professional societies. So apart from what you've described about the members of the guideline group, obviously the new conflict of interest policy, how does it work in terms of the academy? So the academy presumably gets some money from pharma. What's the firewall that kind of might prevent that from influencing either prioritization of what needs to be studied next, or the guideline process? Thanks.
Yeah, thanks. So that's a really great question, Dr. Boyle. So it's very important to me that I think the Academy has actually been very good at this, that separating pharma from how we choose guidelines and separating pharma from the actual production of the guidelines. So pharma certainly can contribute to the AAD, but the guidelines are not, pharma never sponsors a guideline. So there is like no connection between those two. So if you were pharma and you're donating to the AAD, like you're donating to the AAD, the AAD, it's true, is in turn paying for the guideline. But I think because we do this prioritization process, I would say relatively transparently and across the whole academy, I think we are able, because it's basically, and I had a question, I apologize, I didn't realize that this really long, wonderful comment in the chat was actually personally just directed to me, and I was the only one seeing it. There's a question about alopecia guidelines, which we don't have. And the reason that we don't have alopecia guidelines is that's actually never reached a high enough priority score for the academy. So I actually don't have the ability. So I think what's nice is, as chair, I actually have no ability to say, hey, yeah, we should do a guideline on that. I actually have zero ability to do that. And I actually like that, because it actually is the entire academy deciding. I don't know, Lindsay, if you have access to just that slide where we show our 7 prioritization criteria. So we actually, we should have put it in this talk. We didn't, it's not in this talk, Lindsay, but it's in, I don't know if you have it, you may not, but it was the talk that I gave for the guidelines committee. But we actually have 7 different criteria on which they are voting. So, and what happens is it goes out to the academy to hundreds of members through their task forces. So basically be all, the Committee on Science and Research, the Executive Committee, the Conflict of Interest group. So all of these different committees across the academy are all sent basically this survey. And then they're scoring across 7 different criteria. We've actually talked about adding an 8th, because we've been talking more about diversity, equity, and inclusion. And there is nothing in the prioritization process right now about, what does this mean for people with skin of color? Or what does this mean for access? That's actually never been part of the prioritization. And so we're pushing to maybe add an 8th criteria for what does this mean for, for skin of color, for example, which might change, where you put like lupus guidelines or something like that, just as an example. So yeah, so actually as chair, I have zero ability to choose what the next guideline is. What happens is it goes out with these 8 criteria, and I apologize for not remembering off the top of my head. I literally gave a presentation on Monday, but it's going to take me a while to find the slide deck. But it includes, so literature review is how much literature is one small piece. It's like 1/8 or 1/7 of it. The other pieces are things where there's like confusion or discord, basically, in terms of also things to think about is like how it affects people getting reimbursed. So if it's something where the insurance companies are threatening to not cover something, that might be a reason that we would need a guideline in that area. Or as you mentioned, like new guidance coming out, or other priorities, areas of need. So we actually have a whole set of criteria. And so the evidence review is just like 1/7 of that. But I would love to see, is there a way, that when we send out the prioritization, you can give people a sense of what is the new literature, there.
Great, thank you. And also the idea of working closer with the European guideline group, I think that's brilliant as well, because they're well aware that the parallel atopic dermatitis guidelines coming out at the moment, aren't there? And I know there's communication, but I think one of the things we've realized with the pandemic is we're not all that different, are we? Once we're on Zoom.
No, we really are. Oh, thank you. I think it looks like, I don't know if you guys can see your screen, but yeah, here's the, thank you so much, Lindsay, for finding that. I don't know how you found that so quickly. But these are our 7 weighted, and we don't actually weight these all equally. Oh, it just disappeared.
Okay.
Yeah, so they're not weighted equally, but so the value to the specialty, variation in practice patterns, as I was talking about, kind of with the idea of almost like discord where people aren't doing the same thing, importance to managed care, or how, and again, these are American based, but how people are getting reimbursed, and then how it relates to quality or performance improvement activities, and then amount or quality of evidence is one of them. And then public health importance or value to medicine is importance of, obviously in the case of the pandemic, or for example, and then timeliness. Like, is this like an urgent need? So those are the criteria by which the Academy votes. And so to answer that person's question in the chat to me from Spain, is that we don't have alopecia because it's not risen to the top of these criteria. And it may do in the next prioritization cycle, but that is actually nothing that one individual cannot actually influence.
I wanted to mention the living guidelines that came up in your talk. So that is the goal in the future someday to incorporate evidence into guidelines as it becomes available in the literature. At Cochrane, we've worked with network meta-analyses that are living now. We have one for psoriasis biologics, and that seems to be a synergy that might be an area for exploring more cooperation. Laurence Lecleach on the line from the French Cochrane leads those efforts, and I think we're seeing prioritization synergy with the Cochrane, and we're seeing this idea of living guidelines, living systematic reviews. They're all a lot of work, and we all need to optimize all of our efforts to try to bring those together. Also, yesterday we had Lisa Barrow talking about conflicts of interest. The Cochrane has a new revised conflict of interest policy for our systematic review authors. And one of the things that's that gray area that you mentioned was getting new conflicts in the year after doing a systematic review, and how do you enforce that? And actually, the FDA, this was pointed out by Pillar, and an author in Science in 2018, and then we actually my lab looked in dermatology and found the same thing, that dermatologists serving on FDA panels for drug approval were getting contracts from industry in the year after they made an FDA ruling. So how you're going to deal with that? There's while we called for a freezing, that hasn't actually happened at the FDA in the US, and AAD and Cochrane have the potential of really being at the cutting edge of minimizing conflict of interest bias by imposing those criteria on our guideline authors. So I commend you for that work.
I do think we have we have a unique opportunity with all of our avenues for post-publication dissemination strategies. So that's sort of, if you will, another area to reinforce some of these policies. So if you do engage in additional relationships during that prohibited period, you won't be party to some of these wonderful dissemination activities, like these webinars that are, taking off, and they're proving to be very valuable and increasing knowledge about both the guidelines, and they're proven to be, by those who have taken the webinars and post surveys, to be a very valuable resource. So there is an extra, telling someone they'll be taken off of publication after it's been published, of course, is not really that effective, but saying that we do have a host of these other activities that are associated with the guideline and dissemination serves, I guess, as a motivation, I would think, to maintaining some of those standards.
I think it's a really good point, because we don't, right now the idea is, and I apologize, I lost you guys for a second as I froze and dropped off, and now I'm on my phone. So I'm hoping, I can't really see anyone, but I'm hoping you can see me. I think right now we're basically saying if someone were to develop new conflicts during the course, they are actually removed. And even if they had contributed to the guideline writing, they would be actually removed from authorship. But you're absolutely correct. Like, how do we handle that when something's been published? I think it's a fair discussion to actually have with the JAD is, do you like remove someone from an online content? That might be a little bit of a hard sell, but possibly, worth it. So I was actually really delighted to see how Cochrane itself was changing its COI during the discussion yesterday. I don't have a great answer to that. That's a great question.
Well, we need to give everybody a 10-minute break before we start in at the top of the hour. I want to thank you so much for being with us today. This was really a stellar morning session, and you really capped it off well. We're looking forward to more collaboration with the AAD. And now everybody get up and do your jumping jacks, visit the bathroom, take care of your pets, and get a cup of coffee. And we'll see you at the top of the hour for a lecture by Hal Williams about how systematic reviews might be getting out of control.